All right, well, I think I'm going to get started. So thank you very much for joining me in this session. A couple of housekeeping issues. I see that most of you have muted yourselves, and that's the way it should be, to avoid unnecessary background noise. So first I'm going to do the presentation, and then after 40 minutes or so, we're going to open it up for questions. There is a chat function in which you can type in your questions. You can also unmute yourself and ask a question directly. However, once you're finished asking your question, mute yourself again, because otherwise, again, we have multiple people at the talking at the same time, so we do need to be a little bit disciplined in these type of Zoom meetings. Okay, to get started, I'm going to be predominantly talking about laboratory tests in myeloma. I am first going to give you a tiny bit of background about myeloma and the Myeloma Center. I didn't know how many people were going to attend who are fairly new to our center. I've been here since 2001. But this program was started by Dr. Bartleby in 1989, so we've had more than 30 years of myeloma care here at UMS. And what you currently see in terms of care really has built over many years, and many physicians, nursing, and other support staff have contributed to the development of our myeloma center. So all of this hasn't happened overnight. We've had more than 11,000 patients coming here from every state in the US and from more than 50 countries. We've done more than 12,000 transplants. And we like to try to give everybody a positive experience. We also like to try and follow our patients long term so that we know what the long-term outcome of our treatments is. And that's sort of a fairly unique feature of our program, that we do have a lot of that long-term outcome data. Then some of the milestones in our program, Dr. Bartleby introduced the two transplants in 1989. And we started doing outpatient transplants in 1991. And the first outpatient transplant was done on a gentleman who's currently still alive and in uninterrupted remission. One of the big breakthroughs in myeloma really was the introduction of the novel drug thalidomide, which had anti-myeloma properties here and which was discovered by Dr. Bartleby. And that really catapulted myeloma from a fairly obscure disease to a disease into which many doctors and researchers were interested. We started doing PET scanning systematically since around 1998 on patients. We introduced gene expression profiling, identified subtypes of myeloma, and starting to do risk-directed therapy. In other words, patients with standard or low-risk therapy got different treatment approaches than patients with high risk. We also established with our long-term follow-up that it's actually possible to cure myeloma. Obviously not everybody's being cured, but at least we could establish the principle. The other feature of our program is that we have laboratory research, and we'd like to bring this research into the clinic. And so it's really from patient to the bench. We collect the samples for research from the bench, we discover things, and then bring it back to the clinic. So that model has been very, very effective. So overall, this program truly has been developed by a very large number of people at all levels in our organization. So it all didn't happen overnight. So what is myeloma? Myeloma is a cancer of the plasma cells. And the job of normal plasma cells is to make antibodies, and the plasma cells live in the bone marrow. Myeloma is more a disease of the elderly. The average age is in the order of 65, 70, but you are able to get this when you're younger. And we've seen patients in their late 20s, certainly a whole slew of patients in their 30s and 40s. Quite often the diagnosis can be delayed in younger patients simply because the diagnosis is not considered. Over time, with the introduction of many novel drugs, the outcome in myeloma is gradually improving, so that's the good news. So myeloma is the second most common hematological malignancy. Again, it's a disease mostly of the elderly. It's more common in males and more common in African Americans. For most patients, we do not know the cause. Exposure to irradiation or Agent Orange in Vietnam veterans are well-recognized causes of the myeloma, but for most people we do not know. These are data from our center, patients who started treatment in 2003 up to 2006 on our total therapy 3A protocol, and we can see that they had an overall survival of more than 57% at 10 years, which is well above the national average, which is the red line showing there. Okay, so myeloma arises from pre-myeloma states, which are called MGUS or smoldering disease. In general terms, the patients are asymptomatic, so although they have abnormal plasma cells, they're not causing any problems. You're labeled as active myeloma when there is what we call end organ damage. The myeloma is causing problems. And these problems typically are elevated calcium, impaired kidney function, anemia, or bone disease. When the disease is more advanced, the myeloma cells can become more mutated and acquire the ability to grow outside the bone marrow. Now, for MGUS, your myeloma protein is less than 3 grams per deciliter, and your number of abnormal bone marrow cells is then less than 10%. And in smoldering disease, your myeloma protein is over 3 grams per deciliter, or you have more than 10% abnormal plasma cells in the bone marrow. So this definition of smoldering myeloma has recently been updated to incorporate 3 other criteria. These are the presence of 60% or more plasma cells, a high free light chain ratio, more than one focal lesion on MRI. Initially, these patients were classified as ultra high risk myeloma, but if you have any of these features, your risk of progression to active myeloma is so high that it was decided to group these patients into the active myeloma category. So now we not only use the CRAP criteria, but the so-called SLIM criteria. And S is the 60% plasma cells, LI is the high light chain ratio, and M is the letter used for the MRI. So in general terms, patients have produce an abnormal immunoglobulin which is made by the myeloma cells and or free light chains. There are abnormal bone marrow cells abnormal plasma cells in the bone marrow, and you can see bone disease. Now, not everybody makes abnormal immunoglobulins or free light chains. The bone marrow can be involved rather patchy. Sometimes a random bone marrow is negative, and not everybody has bone disease. But these are the general features of myeloma. So where do your bone marrow cells live? They live in what we call the axial skeleton. That is the skull, the spine, the pelvis, and the ribs. So these are the very marrow-rich areas where you can find your plasma cells. So in general terms, unless the disease is very advanced, you typically don't find much disease in what we call the appendicular skeleton, particularly like your lower legs or your forearms. So that's where the plasma cells live, and also when they become cancerous, the myeloma cells. So the normal job of plasma cells is to produce antibodies. And there are 5 classes of antibodies: IgG, A, M, D, and E. So that's the name of antibodies. This is what an antibody looks like. There are 2 heavy chains, which are either IgG, A, M, D, or E, and 2 light chains attached. And the light chains can be of kappa or lambda variety. So you can make an IgG kappa antibody, or an IgG lambda antibody, or an IgM kappa, or an IgM lambda. So plasma cells produce whole immunoglobulins. Okay? However, they also make a little bit of extra kappa and lambda. Excuse me. And these are normal plasma cells. So everybody makes a spectrum of antibodies, and normal kappa light chains and normal lambda light chains. So when the cells become cancerous and become myeloma cells, they start to churn out one type of antibody, and often also one type of light chain. So these are the types of what we call monoclonal protein, or antibody of one type that we see in myeloma. For instance, IgG kappa, IgG lambda. So in 80% of myeloma cases, a heavy chain and a light chain is made, and these are assembled together as one type of antibody. Very often, some additional light chains are produced as well. So for instance, you can have IgG kappa plus 3 kappa myeloma, or IgA lambda plus 3 lambda myeloma. So this is important to know, because it means you got 2 markers to follow. So you can follow the IgG kappa or the IgA lambda. You can follow the IgG kappa and the 3 kappa and the IgA lambda plus the 3 lambda. Now about 20% of patients only make the light chains, so they make either only 3 kappa or only 3 lambda. And then again, there are about 3% of patients who do not make any myeloma protein whatsoever, be it the whole antibody molecule or the light chains. So what are the ways of measuring myeloma markers in the blood and urine? First, we can quantitate the antibodies, the IgG, A, M, D, and E. We can also do a serum protein electrophoresis to measure the abnormal myeloma protein. Then there's an immunofixation test which identifies specific proteins. So it's an antibody test which identifies IgG or A or M, and it gives you a yes or no answer. It's not used for quantitation. Then there are also the assays of the 3 light chains. So you measure there either the 3 kappa and the 3 lambda, and you can express these as a ratio. So we also do 24-hour urine collections to measure the amount of total protein in the urine and amount of light chains in the urine, since the light chains can be excreted in the urine. So your serum protein electrophoresis can quantify the amount of abnormal antibody produced, and we refer to that as the M protein or M spike. The quantitative immunoglobulin assays measure IgG, A, M, D, or E, but it doesn't tell you whether this is normal IgG, for instance, or M protein, and the M protein is solely made by the plasma cells, the one type of IgG made by the abnormal cells. The immunofixation is a test used to identify what type of abnormal protein or light chains there are. So this gives you a yes-no answer. It tells you something about the type of protein that's present, but it's not used for quantification. The serum-free light chain assay measures light chains which are not bound to a heavy chain. So it truly quantitates free light chains. And again, I've already alluded to the 24-hour urine in which we measure total protein and light chains. So all of this is a little bit complicated, these markers. So this is what the serum protein electrophoresis looks like here in the top hand corner of the slide. These are proteins separated by charge. Here you see the albumin fraction, and albumin is the major normal protein in your blood. And this is what we call the gamma fraction, and here you find most of the myeloma proteins, and here you see a big spike. And this is where you find your myeloma protein or M spike. And this is literally measured as area under the curve. Now, in the serum immunofixation assay, the serum of the patients is incubated with antibodies against IgG, A, M, kappa, and lambda. And here you can see that that there's reactivity with IgA, so there's clearly an IgA band. And there's also an antibody against lambda, and clearly lambda is recognized. So this tells you that the patient makes an IgA lambda type of M protein. Now, under normal circumstances, the antibodies have a light chain attached to it. That's either kappa or lambda. And then there can be circulating free light chain, low levels in normal individuals, but elevated levels in patients with myeloma. So in the old days, the light chain assays used to detect the light chains regardless of whether they were bound to the heavy chain or not. And the free light chains truly only detect free light chain and not light chain complexed with heavy chain. And I'll explain that in more detail a little bit later on. And here's the slide. So if you look at the light chain here bound to a heavy chain, there is a hidden surface and an exposed surface. So when you look at the free light chains, the free light chain assay only detects the hidden surface. So only when it circulates as a free light chain, not bound to the heavy chain, can this assay pick it up. So it can quantify truly free light chain kappa and lambda. Important to realize is that these assays have normal ranges. Because again, normal people have free kappa and free lambda in their peripheral blood. It's also important to realize, particularly when you go back home to your local oncologist, that the kappa and lambda are expressed on two different scales. In other words, there are two ranges for normal values. One uses 3.3 to 19.4 milligrams per liter for free kappa, and 0.33 to 1.94 milligrams per deciliter. And same difference in the normal range applies to free lambda. So we use the lower ranges, the milligrams per deciliter one, but you may find that your local doctor, when he runs the blood test, actually expresses it in milligrams per liter, and the normal range is higher. So there's also a normal kappa lambda ratio, and this can be quite difficult to interpret, and I'll talk about that in more detail. So in general terms, you look at the absolute value of kappa or lambda. So if your myeloma makes extra kappa or lambda, you should look at the absolute value and not necessarily at the ratio. And I'll try to explain why, because the ratio can be quite confusing. Now, when do you look at the ratio? The light chains are excreted via the kidneys. So if you have renal impairment, and for instance, you have free kappa myeloma, not only your free kappa will be elevated, but your free lambda as well. So you'll get a skewed free kappa lambda ratio in that regard if you have free kappa light chain myeloma and you have renal impairment. If you don't have myeloma, both your kappa and your lambda will be elevated, but the ratio will be normal. So if your kappa and lambda concentration are abnormal because the immune system is activated and normal plasma cells churn out extra light chains, that doesn't mean that you have myeloma. You can see that the ratio is normal. However, if you have myeloma, you can have, for instance, excess free kappa, but the lambda can vary and it can be quite abnormal and abnormally low. That can make the ratio very difficult to interpret. For instance, if your free kappa is elevated to 10 and your lambda is less than 0.01, the ratio is infinitive. In other words, the kappa lambda ratio doesn't have any significance. And why is that so? The opposite light chain, in other words, the light chain that your myeloma cells do not make, but which is made by the normal plasma cells, can be very low, essentially because of two reasons. The normal plasma cells are being crowded out by the myeloma cells, or alternatively, the myeloma cells have been completely suppressed by the treatment. So, in other words, you need to be quite cautious at looking at these ratios, because if the normal light chain, which is not made by the myeloma cells, is for any reason quite low, then you get artificially elevated ratios. So that's why I tell people, in general terms, look at your absolute kappa or your absolute lambda, and don't pay too much attention to the ratios, because they can confuse you and they can vary quite considerably. I'm not saying that they cannot be informative, but they can be the source of considerable confusion. So let's go to the protein electrophoresis and immunofixation. And Dr. Hoda Hagras is the head of our immunology labs, and she's an expert in quantification. She was so kind to give me some examples of electrophoresis and immunofixation. So let's go to the next slide. This is a protein electrophoresis strip, and essentially the proteins are separated by charge. This is the major band in the blood of the major normal protein, and this is called albumin. Then there are alpha regions where large molecules are present. There is a beta region, and in the gamma region, quite often, as is the case in this particular protein electrophoresis, the myeloma protein can be found. The immunofixation test. Here you put the serum of the patient in multiple wells, and you apply an antibody to it. This is an anti-IgG antibody, an anti-IgA antibody, an anti-IgM antibody, an anti-kappa antibody, an anti-lambda antibody. Now you can see that there's a smear here, which means that there is a whole variety of IgG antibodies being recognized, a whole variety of IgA antibodies being recognized, and there's not, and also a whole variety of kappa chains being recognized. In other words, there is not one specific M protein present. Now look at this. So here, this is shown more schematically. This is what we call a polyclonal pattern. You can detect IgG, you can detect IgA, you can detect IgM, you can get kappa and lambda. So this is a so-called polyclonal pattern, and this is quite normal. This is what you see in a normal individual. So let's go then to what you see in a myeloma patient. And here you can see on the protein electrophoresis a band in the gamma region, and if you do the immunofixation assay, it tells you that this band is IgG, and there's reactivity with 3 kappa. So there's the M spike. What is it? It's an IgG kappa myeloma protein. So the immunofixation is a non-quantitative assay. It tells you what type of protein there is, but it's not used for quantitation. The area on the curve here tells you what type of, tells you the amount of myeloma protein there is. Okay. So when we do these immunofixation assays, I can't tell you how many inquiries I get for patients because they get confused. Because sometimes the immunofixation assays tell people there are multiple bands. And what does it mean? Now, first of all, there are patients who have two myeloma clones. So they make, say, an IgA kappa antibody, an IgG lambda antibody. Now this is rare, okay, maybe a couple of % of patients at best, so that's very uncommon. There is also something which is called immune recovery, and it is often after transplant or after treatment, and the immune system is start to make IgG, A and M as it should do. And you can see little bands appear, so you can see multiple bands appear, and this is called also oligoclonal bands. So this means that there is immune recovery, and that's very common, and actually that's a good feature. And quite often this is cause for concern because the patient thinks, hey, the immunofixation test shows bands, so my myeloma must be coming back. So we have a number of antibodies available. There is Darzalex, there is isatuximab, there is elotuzumab, and there is now a new antibody called belantamab. And all these antibodies are of the same isotype. They are all IgG kappa antibodies. And obviously, because they're antibodies of one type, you can actually recognize them as a band on the immunofixation assay. So they sometimes can cause confusion. However, usually the laboratory is aware of this, and they know where these bands run, so they can discriminate between the abnormal myeloma band and the IgG kappa band derived from the monoclonal antibody. So let's look at an example of multiple bands. You can see here bands in the IgA region, also in the IgM region, and these are both lambda. So there's an IgA then these are both kappa. So there's an IgA kappa protein and an IgM kappa protein. And there are also, although it is a little more difficult to see, there might be also some lambda bands there. So this is the report that went out. There's an IgA kappa protein present, there's an IgM kappa protein present, and there are multiple IgM lambda bands. And what they do in the lab then, they look back to your original test and say, what type of myeloma did this patient have and where did the band run? So the patient may have had IgA kappa M component, and so this would be the myeloma protein, and the rest is immune recovery. So they look at these immune fixation tests serially and refer back to the original strip so that they can discern which ones are new bands, which are related often to immune recovery or perhaps to the presence of a therapeutic monoclonal antibody, or which one is related to the myeloma. Here's another example how this can change over time. So here's a patient who got a clear spike in the gamma region on serum protein electrophoresis. And the immune fixation assay tells you that it's an IgG kappa antibody. This was in 2009. Now look what happens in 2017 when the patient has a relapse. There's a very small band here in the gamma region, and there is nothing else. However, when you look by immunofixation, there's a big free kappa band there, and the IgG band is small. So what has happened here, the amount of production of the IgG kappa has been greatly reduced, and the patient is starting making free light chains. So this is a phenomenon that is called light chain escape, and you can measure these free light chains by the free light chain assay. So in other words, the myeloma cells have become more mutated and lose the ability to make the whole IgM kappa protein. So in general terms, when the myeloma is still relatively early in its stage and what we call more mature, the myeloma cells are able to make the whole myeloma protein, whether it's IgG kappa, IgA lambda, IgM kappa, whatever it is. They usually also make some free light chains. Then, when the disease progresses and at a relapse, maybe you get production of more light chains. Eventually, the disease can become what we call hyposecretory. So relatively little myeloma protein is made, whether it's the whole protein or the free light chain. And eventually it can become non-secretory. So the implication of this is that you should not only rely on your myeloma protein, and all of you who are myeloma patients know that we essentially do three things to monitor the myeloma. And this is exactly for this reason. We look at the myeloma protein, we look at the light chains, and then we look at the bone marrow to see whether there are myeloma cells, and we look at the imaging. Because the patterns of relapse can be very different. So you can have a relapse, a very little myeloma protein, and there are just cells in the bone marrow. And there are no hotspots on imaging. Then you can have a relapse where it's all in the imaging. In other words, you'll only see something abnormal, MRI or PET scan, your light chains are normal, and the random bone marrow is entirely negative as well. And then you can have every combination of the three. So it's important to monitor and understand these three types of tests in context. I also would urge you, when you look at these myeloma tests, not to compare them with the patient that you're meeting in the treatment room or in the waiting room, because everybody's myeloma is different, and to some extent everybody has their unique myeloma with their own unique makeup, and everybody's myeloma tells a little story. So in some patients with myeloma, I pay much more attention to what is happening in the focal lesions. And sort of what's happening with the myeloma protein and the bone marrow might not necessarily be that interesting. So there is every myeloma has its own, what the Germans call Gestalt, unique picture. Okay. So what do we follow in the myeloma markers? What we look at, we do look at the IgG, the A and IgM. We look at the M component, and we look at the light chains. We mostly look at absolute values, sometimes with ratio. Another important myeloma marker, which we haven't discussed, is called the LDH, and that is secreted by plasma cells. And quite often, it's a marker of more aggressive myeloma, and also a marker of patients who have myeloma which is growing outside the bone marrow environment. Now, to highlight another point of confusion, okay, your total IgG, which you measure by the quantitative immunoglobulin assay, measures both normal IgG made by normal plasma cells, which we call polyclonal, and it measures IgG made by the myelomatous plasma cells. That's called the M component. And lo and behold, we made things really confusing there, because the IgG is expressed in milligrams per deciliter, and for some reason the M component is expressed in grams per deciliter. So your IgGs can be 1100 milligrams per deciliter and your M component 0.8 grams per deciliter. And if you would translate to milligrams per deciliter, then this would be 800 milligrams per deciliter. So how much of this 1100 is normal IgG made by normal plasma cells? So we shouldn't subtract 0.8 but 800. So your polyclonal normal IgG, the normal IgG antibody here is 1100 minus 800 is 300, and that's low. And that's an indication sometimes if patients have repeated infections for IVIG replacement therapy. So the fact that this IgG or your IgG A and M and this M component are expressed in milligrams per deciliter and grams per deciliter is very confusing. And to my mind, it would have been much better if this would have been in milligrams per deciliter. It would be much easier to understand for people.
Still be lost.
Okay, so it's all not that easy. So we also do the 24-hour urine. One, because you can measure the response, and we measure the total amount of protein in the urine, and we also look how much light chains there are in the urine. So the whole IgG, A and M are not secreted into the urine, but the light chains are. And this is important because myeloma can affect the kidneys in different ways. And I think I will confuse you all with this, but there are three major types of kidney disease. One is that the light chains deposits as cast in the kidneys, and typically the amount of total proteinuria matches the amount of free light chain proteinuria. And just by doing a 24-hour urine, you can figure that out. And the importance of this is that this type of myeloma-induced kidney disease is very reversible. On the other hand of the spectrum, when the light chains deposit in the kidneys as clusters, which we call amyloid, you can, for instance, have 10 grams of proteinuria, and it's all albumin, and there's no loss of free light chain. And this is very much less reversible. So these 24-hour urines can give you insight in what type of myeloma kidney disease there is and how reversible it is. So it's a monitoring tool to see whether something is happening. It also can give you insight what type of kidney disease there is developing. And I think this is 40 minutes, so I'm going to stop here and give you some opportunity to ask questions. So this whole business of the myeloma proteins is not that easy, isn't it? And it requires quite a lot of thought. So we have the serum protein electrophoresis to detect the myeloma protein. The immunofixation assay tells you what type it is. Then we can measure the serum free light chains. We need to be cautious in interpreting the ratios. And there is also an assay which measures just total IgG, A and M, regardless whether it's myeloma IgG, A or M, or normal IgG, A or M. So there you are. Those are your myeloma markers in a nutshell. And I hope that I didn't mean to confuse you too much, but it's really, it's not that easy and straightforward. And you do need to take care, be cautious in interpreting these things. The other point to make is that you should not stand on one leg. When I look at myeloma markers, I really look at trends. So, to make things a little bit more complicated even, these assays are not super accurate. So if I measure my IgG today and 700 and I do it 2 weeks later and it's 900, that may not necessarily be clinically significant, because these, there can be some more production of normal IgG. So this is what I call, these are living values. So really, you need to see trends, and trends are much more important. And that's sometimes why, that's certainly why we'd like to see, in general terms, monthly myeloma markers. And sometimes when it's really important, we want to see them every 2 weeks. So trends are very much more important than a single value, which can vary from a couple of weeks to a couple of weeks. Or even when you run the same sample twice, you can get a different answer. So these values are not cast in stone. All right, so I'm going to pull up my control panel and see whether we got some questions in chat. So I don't see questions in chat, so I'm going to invite you, if you have a question, to unmute yourself and post a question. I'll try to answer it the best way I can. So in order to answer your question, ask a question, your mute and unmute button may be on the left lower hand side of the Zoom screen. There's a video icon and there is a microphone icon. And don't be scared to ask some questions. Go ahead. I think I managed to confuse you all. Okay, there is somebody. Yeah.
Hi. My name is Adam Schwabe. I had a question about, I hear a lot of discussion about, oh, negative MRD. What exactly does that mean? Or, uh, I mean, can you maybe give us a little summary of that, or
Sure,
is that like
absolutely.
a goal?
Okay, so MRD is a test done on the bone marrow, okay? And even when the bone marrow, it looks normal on the microscope, it can detect small numbers of abnormal myeloma cells which are not visible. And there are two basic tests for it. One is called flow cytometry. And this is the test that we run here routinely on every marrow, on everybody. And essentially, you label the cells with antibodies specific for myeloma. You run them through a machine. The machine recognizes the abnormal cells in the middle of a sea of normal bone marrow cells, and you can quantitate it. And the sensitivity of the assay is that you can recognize 1 million cells between 100,000 normal cells. The other test is a molecular test, and it's done by adaptive, and we call it the clonoSEQ. And what you do is that test you detect the genes that encode for the abnormal antibody, and that is sort of a barcode for the abnormal myeloma cells. And you sequence these abnormal barcodes in the marrow, and you can detect as few as 1 in a million myeloma cells in the bone marrow, in the midst of 1 million normal cells. So the way we do it, we run on everybody the flow test with a sensitivity of 1 in 100,000. And if the flow test is negative, then we send it to the adaptive company, and they can do the tenfold more sensitive molecular test. Now, sometimes insurance doesn't pay for it. Medicare does, but some private insurances don't. So unfortunately, we can't run it on everybody. The idea is that myeloma, and I'm just going to go out of slide mode here. Maybe I should show you a few slides. So the idea behind this is that there can be quite a few myeloma cells detectable even when the myeloma looks normal, when the marrow looks normal. And let me quickly, I'm opening another file here. Okay. So if you think about disease like a big iceberg, okay, this part is what we can see under the microscope. But in the body there could be still a very large number of myeloma cells detectable, and that's what you detect by the MRD assay. Now, what's the significance of that? We know that MRD positivity after induction chemotherapy, after transplant, and during maintenance has prognostic significance. In other words, if your MRD assay is worse, statistically you have a higher chance of relapse. Now, there are some, let me just quickly go through this and make the important points here. So, for instance, if you're MRD positive and you're in remission, by standard criteria. Your bone marrow looks negative. You do worse than when you're MRD negative. This is an analysis of 3 Spanish clinical trials. And however, there are some caveats here. So here we look at low risk disease after transplant. So here, if you are MRD positive 2 years into maintenance, then you do worse. But not when you test early on in the maintenance therapy after the transplant. That means that the maintenance therapy is still busy eradicating myeloma cells, and you need to give maintenance therapy time to work. So MRD positivity in our hands is more important later on in low-risk disease. If you have high-risk disease and you're MRD positive 8 months after transplant, you have a very poor outcome. So any surviving cells after transplant, by whatever method detected in high-risk disease, have immediately after transplant already an adverse prognostic meaning. Then, I don't know why I have that slide, okay. So it is also important to realize that some types of myeloma don't go into complete remission or don't become MRD negative, and the cells sort of just sit there. In other words, they don't grow. They're indolent and they don't do anything. And there are some molecular subtypes of myeloma which behave like that. And I may have been in the clinic with one of you and say, well, I think that your myeloma is not going to go MRD negative and it doesn't make any difference. Because your outcome will be equally well and you just have got some residual cells after treatment and they're not going to do anything. They're just going to survive and sit there and be asleep. So it's not a question about just MRD negativity or positivity, but also what type of cells have survived and what the biology of the disease is. Now, where are we going with all of that? So we do know that in general terms, MRD positivity has prognostic significance. However, what do we do with the information? Does it make any difference if we have MRD positivity and we alter therapy? Do we improve outcome? Conversely, if somebody is MRD negative, should we stop maintenance early? Or is this a bad idea? Because people who are MRD negative still continue to relapse. So look here, these are patients in complete remission. They are MRD negative, but they're still ongoing relapses. So maybe you need to have, for instance, serial MRD negativity on repeat assays in order to make a judgment call whether you can stop your maintenance therapy. So at the moment there are at least 15 clinical trials in progress to try and figure out whether you can change your therapy based on an MRD test and whether this improves outcome, or whether you can give less therapy based on an MRD test. So at this moment in time, in 2020, we only know that MRD positivity has prognostic significance in about 80% of patients. But we don't know whether altering therapy actually improves outcome. So that was a long, complicated answer.
Thank you. I appreciate it.
Did you follow it a bit? Because it's a complicated topic.
I did. Well,
yeah.
At least I think I did.
Yeah. It's really the subject of a complete talk, isn't it? It's we can talk about this for about another hour. It's a very complicated topic, and you know there are many clinical studies ongoing at this moment in time in this area.
one more quick question. I don't want to hog the time, but is the differ. Well, I guess the criteria for high risk. It seems to me that it's kind of evolved over the past couple years. And what's the most current criteria that you all use to make a determination for high risk?
Okay, so the answer, there is no such criterion. Okay, I mean, even in the field, people use different criteria. The most commonly one used is the Revised International Staging System. However, there are things like gene expression profiling, there are things like metaphase cytogenetics. We really know that the imaging is extremely important, especially the PET scanning and also the whole body diffuse and weighted images MRI. So when I decide whether I think somebody is high risk or not, I actually take multiple things into account. And the field has not defined any imaging criteria to label somebody high risk. And we actually defined first MRI as a prognostic indicator, independent prognostic indicator in 2007, and PET scan in 2009. So we've incorporating imaging variables in our assessment of high risk for a long time. So you are absolutely correct that there are different criteria for high risk. Even in the way people use a certain high risk criterion can be very confusing indeed. How many cells need to be positive to call a Fish abnormality? For instance, we find that if you have deletion 17p in 20% of cells, that doesn't make much difference. However, it's very significant if you have it in 60% of cells. So how you apply these criteria is another cause for confusion. And for a patient, it's sort of a nightmare to look at all these different systems that are out there and trying to figure whether you're high risk or not. And you really need to discuss that with your patient, with your doctor, and understand what criteria he uses.
Thank you.
And actually, that's the subject of another talks. That would be a really good talk to give. What is high risk disease and what criteria do we use? All right, there are 32 of you. Somebody else must have a question.
I have a question. Dr. Van Reed, what percent of myeloma patients would you say will experience renal failure, whether it's chronic or just renal failure during their treatment?
They usually get it. During a diagnosis. Sometimes, if somebody's prone to renal failure, then it can recur at relapse when the myeloma reaccumulates. So the principal causes for renal failure are the light chains affecting the kidney as nephropathy, amyloid, etc. Also hypercalcemia, and then there is also the possibility that some of the treatments sometimes can cause trouble. So let me show you here. So renal insufficiency occurs in about 20% of patients. Fortunately, it's very often reversible, obviously not always.
Okay, so if a patient's diagnosed, so in the early stage of treatment, they could possibly experience the renal failure, but it could be rectified later on after treatment.
Correct. The rule of thumb is that renal failure in myeloma can be reversible in the first 3 months, and perhaps up to 6 months. But if you have a creatinine, say, of 2.5, 7 or 8 months later, then that's not going to get better. So you have a window where you can improve renal function by correcting calcium, by treating the myeloma, by getting rid of the light chains. But at some stage, the kidneys become damaged and they will not improve any further.
Does this also occur in patients with lymphoma, or have you seen that occur?
It can occur in lymphoma, but so myeloma is much more likely to cause renal impairment. First of all, production of light chains in myeloma doesn't occur very often. Patients can get high calciums causing renal impairment. And lastly, when the tumor breaks down rapidly as a result of treatment, the kidneys can become overwhelmed and not be able to clear all the toxic substances released by the dying cells. And that's another mechanism of getting renal impairment in lymphoma. But in general terms, renal impairment is much less frequent.
Okay, thank you. That answered my question.
Question, in patients with plasma cell dyscrasia, kappa restricted, involving 5 to 10% of the bone marrow cellularity, with a diagnosis of smoldering myeloma, are they candidates for bone marrow transplant?
Well, in general terms, not. Okay, so there is the question in the field, should we treat patients with smoldering myeloma? The idea is that they're less mutated, that you can eradicate the myeloma completely, and that you prevent the development of myeloma. So there have been trials with lenalidomide and dexamethasone, trials with using comprehensive treatment approaches, including transplant. However, you only expose smoldering patients who are entirely asymptomatic and have no problems whatsoever to treatment, in my view, if they're at high risk of progression to myeloma, and there are a number of markers for that. So in general terms, you don't treat smoldering myeloma at all unless it's high risk, and I think it's debatable whether you should do an autotransplant for smoldering myeloma. With the availability of novel therapies, including carfilzomib, Darzalex, etc.
So would you suggest an auto transplant, bone marrow transplant?
Not for smoldering disease. So the Spanish have done a clinical trial for patients with smoldering disease at high risk of progression, and they had a comprehensive treatment approach, just like they were treating normal myeloma. But the downside of that is also that there were 1 or 2 patients who died as a result of the treatment, and at the time of instigating the therapy, they had no problems whatsoever, so, apart from the potential toxicity. So you have to be careful with that. So although I'm an enthusiastic transplanter, I'd rather wait a little bit until there's early myeloma rather than, just high-risk smoldering myeloma. Particularly with the availability of 4 drugs combinations. You can use a proteasome inhibitor, immunomodulatory drugs, dexamethasone, and a drug like daratumumab. You can have 4 active drugs to attack the myeloma and get the patients into remission.
Dr. Van Ree, does it change you were just mentioning the four drug combinations. Would you still use 4 up front with a patient who has the renal impairment? Or how does that change how aggressive you treat?
Okay, so first of all, somebody presents with myeloma and renal impairment. You need to get rid of the myeloma and suppress the light chain production. Otherwise, you're not going to save their kidneys or improve the kidney function. So, unless the patient is really sick for other reasons, it's not a reason to skimp on treatment. To the contrary, you should get on and treating the patient appropriately and rapidly reduce the myeloma. Does that answer your question a bit, April?
Yeah, you got it.
Yeah. All right.
Good evening, doctor. I have a question.
Sure.
You mentioned that you don't necessarily recommend therapy if you have if you're in the smoldering myeloma phase and non-symptomatic or asymptomatic.
Okay, so that's not a categorical statement. I think you can seriously consider treatment for patients who have high-risk smoldering myeloma, who are at increased risk of progression, ideally in the setting of a clinical trial, but you can also do it outside the clinical trial. But I don't think that everybody with smoldering myeloma should be treated.
Okay, so if you have, well, first, I guess, what do you consider high risk? How do you know that you're high risk? And then the second part of that, if you are not high risk and you have smoldering asymptomatic, what do you recommend so that it doesn't progress into something worse?
Well, if you, okay, so again, for who has high-risk smoldering disease, there are a number of predictive systems, and I'm trying to put this on slideshow.
Okay.
And it's not doing it. I don't know, okay. Anyway, some markers are for a higher risk of smoldering myeloma are, for instance, determined by the height of M protein, by whether the uninvolved immunoglobulins are suppressed, the free light chain ratio. So there are a number of factors. We've used in the past a gene expression profiling score. So there are different ways of interpreting who is likely to progress. So what is commonly used now, okay, and I wish I could put this on slideshow, and I don't know why it's not doing it. Okay, here we go, because I had another slideshow on. Okay. So this is the most commonly and so-called modern model. It's called the 20-20-20 model. So you have one risk factor is 20% more than 20% marrow involvement, M component over 2, and the free light chain over 20. And the more of these risk indicators you have, the more likely you are to progress over time. So this is referred to now as the revised Mayo model, but there are other models are as well. There's an NIH model, there's a Spanish model, then we have a model, And increasingly people are considering the M component not a static measurement, but you look at 2 or 3 measurements over time. So you look dynamically whether these patients have increasing abnormalities in the M component free light chain, which is much more informative. So I'm certainly not against treating people with smoldering disease, but you do need to identify those who are at high risk. I think that's really important.
Thank you.
I'm sorry. You provided some amazing information, so thank you for that. I have a family member newly diagnosed. So my question is your slide presentation available so that we could view it again?
Sure. I think Linda may correct me, but I think we can put it on Facebook.
Okay, that would be wonderful, because you have a lot of answers to the questions in here. I just have to look through it another time slower.
Well, it's actually very overwhelming, because this stuff, like even the myeloma markers, it's pretty complicated. It's not that easy.
Right, but you're doing a wonderful job breaking it down, so I appreciate that.
You're welcome.
And another question, doctor, to tag in on that same topic that you're on. Is anemia, renal insufficiency, bone pain, and those other risk factors, are they considered, would that place a patient in the high-risk category?
So no, that does not make you high risk. So there are many analyses, including at our own center, which shows that renal insufficiency does put you at somewhat greater risk of a poor outcome, but that's not necessarily all related to relapse. It has to do with how much treatment you can give, the complications you potentially can get. So renal insufficiency is not a biological indicator of high risk. It doesn't mean that the biology of the cancer or the mutational profile of the cancer is high risk.
Thank you.
So to explain this further, so usually the problem lies in the light chains. So and what determines whether the light chains cause havoc in the kidneys is the proclivity, the tendency of these light chains to do damage to the kidney. So, for instance, you can have 5% plasma cells in the bone marrow, no other problems, and you got and you make very little free light chains, but the little free light chains that you have, they all get stuck in the kidney, and you got a problem. You got renal insufficiency. Conversely, you can have 50% myeloma cells, and you have a free light chain level of 1,000, but the free light chain level that the patient makes don't have the tendency to get stuck in the kidney at all. So there's no renal insufficiency. So it is determined by the tendency of the myeloma of the free light chains to affect the kidney.
And I'm sorry, while you're still on that, does the ratio of the light chains matter? You're talking about the kappa and the lambda ratio, whether you have 20 to 1 of what, 20 to 1 versus kappa and lambda? So
it's predicted. It's one of these predictive factors for MGUS and smoldering disease. In general terms, it is thought that the height of the light chains is not necessarily a predictive factor. However, we have shown that the pace with which you clear the light chains is a predictive factor. And this has to do with the fact that you have high-risk disease. So paradoxically, if you have high-risk disease and the cells grow fast, they're more sensitive to chemotherapy, and the reduction in your light chains is much quicker. the half-life of light chains can be measured in hours. So the light chains can come down very fast. So patients who go into remission very quickly, we always worry about. Sometimes going slower into remission in myeloma is not necessarily a bad thing. So the other thing to realize that the half-life, for instance, of IgG is 17 to 21 days. So the pace with which the M component of an IgG molecule comes down is much slower than the rapidity with which the light chains diminish in number. So if you're interested, we actually published a paper on that, I think in 2009, that time frame, yeah.
Okay, thank you.
All right.
Dr. Henry,
Yeah.
I have a couple of questions if you have time.
Sure, go ahead.
Okay, on the there's really two questions basically. On all of the IgG and IgA and IgM, of course, there's a range of values, and then there's a range, I guess, that's considered normal. When you're looking at those values, is it better if those are in the higher end, or is the lower end better? Like, what's when they're above or below that normal range? What's better, or what's a good number?
Ideally, obviously, you don't want to have abnormal values. I mean, ideally, you want to have a normal IgG level. If the normal IgG is low, then it means that you're not making enough antibodies and you're more open to infections. If your IgG is high, it probably means that there's myeloma protein there, and as indicator of that myeloma is present, and usual also means that your normal IgG actually is low. I showed you this calculation. So in general terms, normal range is better, provided obviously it's all normal IgG and not IgG which is of one type produced by the myeloma cells.
Okay, and the second question is, when you have your normal, and I think you kind of went over this a little bit, but I didn't quite get it. When you just take the IgG and IgA and IgM values, and then you do the serum to extract, like if you're on the daratumumab, to extract that and really understand what's the effect of the medicine and what's just normal. Should you expect to see those values be higher once you do the assay to eliminate the medicine, or should those values be less than your baseline, if that makes sense?
Okay, so there are different scenarios possible. I'm just trying to find the slide here. I think it's... Okay, I need to get out of slide mode here. Okay, and then I can put this one on. So, what you measure, what you need to look at is what is the M component. You translate that to the same value, milligrams per deciliter, and then you can calculate from the amount of total IgG, which sort of measures the normal IgG and the bad IgG from the myeloma cells. And you can see how much normal there is and how much bad there is. And obviously you would like to be your normal IgG in the normal range. And ideally you don't like there to be any myeloma-derived IgG. I'm not sure whether I answered your questions correctly.
Well, so what would I see, like, after, if the normal, if you take the blood count and the test and you're at the 1100, and then are you saying that once you do the assay, your value would show 300, and that's
No, this is
that's
a calculation you do based on the available data, based on your IgG value and what your M component is. If your M component is 0, then this is all normal normal IgG.
okay.
Okay, so if you have a value of 1100 and your M component is 0, it's all normal. If your IgG is 1100 and your M component is here 1100, then you got no normal IgG.
Okay. So your value, your IgG value is 300.
In this particular instance, your normal IgG is 300. So the IgG assay or the IgA assay measures both normal IgA and IgA made by the myeloma cells. It doesn't discriminate.
Mm-hmm. Okay. Thank you.
You're welcome.
May I tag on that same idea? So if you have a IgG monoclonal gammopathy with the M spike with the IgG, is that the myeloma component that you're referring to?
Yes, the M spike is the myeloma component, absolutely.
Myeloma component, right?
Yeah.
And if you had a monoclonal IgG gammopathy, then it's mainly that IgG component, right?
No, the monoclonal gammopathy is a word for MGUS, isn't it? So that's a disease for a pre-myeloma stage, which we call MGUS.
That's pre-myeloma.
Yeah.
Doctor, I have one more question. How often can a patient safely get bone marrow biopsy?
Well, the answer, some of our long-term patients who are on this call will know that, isn't it? So you can do safely bone marrows for a long period of time. I mean, we have had patients who literally have had 30 marrows over not obviously in a year, but over many, many years. So you can do safely bone marrows, certainly.
Okay, thank you.
I'm not saying that it's fun to have a bone marrow, obviously not, but it can be safely done.
How many bone marrow transplants can an individual have in a lifetime?
Okay, so in general terms, we collect a lot of stem cells here, and for many patients we do 2 transplants, so we collect enough for 2. Then we always want to have enough for a 3rd one. We have had rare patients who have 4 or 5 transplants, but that's a scenario you would like to avoid. Nobody wants to do 4 or 5 transplants on a patient. And we also hope with the effectiveness of the novel drugs that we can get away from doing salvage transplants. At the moment, the tendency is that patients with high-risk myeloma should be considered for a double transplant. Now, we do double transplants on many patients because we get such good results with it. But I think that there is not that much argument in the field that high-risk patients should get 2 transplants and still benefit from that. However, we are getting novel therapies online, particularly antibody products, bispecific antibodies, The CAR T cells are logistically difficult to make and expensive, but it's a rapidly developing field, and that may also change the calculation. Also, now we can treat people with 4 drugs up front, and maybe some older people can get away in due course with not doing a transplant, but I think that is all data that needs to be fleshed out in more detail. And we've seen many times in the past that novel drugs improve the short-term outcome, but that transplants, when given up front, still add to the benefit in terms of long-term outcomes. Single high-dose melphalan is still one of the most effective therapies out there. So, but it's going to be a changing paradigm in terms of number of transplants we do, and it's also a function of age. Obviously, if somebody is 40, you would be much more inclined to treat really aggressive than when somebody is 77 and in poor shape. You wouldn't even consider a transplant. So there are many factors which go into that calculation.
Okay, is the success rate higher if it's within a certain time frame after the first transplant?
Okay, if you do 2 transplants, the data in our center show you should do them within 6 months of each other. A 3rd transplant is most helpful more than 3 years after the initial transplant. And why is that? Because presumably the disease is not as aggressive, and patients either have had salvage therapy and survived for 3 years, or the disease comes back later and is and it's a more indolent, non-aggressive relapse.
And you monitor that through the PET scan?
Bone marrow, myeloma markers, and imaging, all 3.
Okay, thank you.
You're welcome.
It's very helpful.
Okay, there are some questions. Okay. So I got one question is, how do the various labs determine how a patient gets treated upon diagnosis and relapse? So one thing that we look at in terms of myeloma marker is the tempo of increase. For instance, when the patients relapse, if you have a rapid increase in light chains, it usually means that the disease is growing faster. So that can have bearing on what type of therapy you use. I don't think that things like whether you have an IgG, A or M myeloma necessarily determines the therapy, nor whether how high the light chains are, for instance, at diagnosis. You wouldn't treat an IgA myeloma different from an IgG myeloma, for instance, or a light chain myeloma different from an IgG myeloma. Okay, somebody asked for a good source for all of this explained in very basic terms. Well, usually a number of advocacy organizations, the IMF, Multiple Myeloma Research Foundation, if you go on the internet, they've got very good videos explaining myeloma to patients. So I'd encourage you to go on the internet, because there's truly a wealth of videos. There's also the Myeloma Crowd, which does podcasts. There's a wealth of information out there, which is not highly technical and understandable to the general public. And you guys are not the general public, which you already know more to start with anyway. All right, I think we're going to end here. I'm very grateful that all of you took so much time out of your schedules to come and listen to me and try to understand myeloma markers and myeloma a little bit better. It will be put on Facebook and you can look at it again. And obviously this is an ongoing series, and we'll be happy if there are requests to either do other topics or to highlight certain things in more detail.
I would just like to personally say thank you, and you have been very informative.
Okay, thank you. It's my pleasure, and it's great to have you all here. Thank you very much.
Thank you for your time.
Thank you for your participation.
Thank you.